to today's webinar. My name is Trevor and I'm the Communications Manager for the Canadian Cancer Survivor Network. Thank you everyone for attending today's webinar, the latest in the fall leg of the 2025 webinar season. If you're new to our webinars, a little background on our group. CCSN works to connect patients, survivors, and other stakeholder groups with decision makers and the wider community to engage in discussion and to act on evidence-based best practices to alleviate the medical, emotional, financial, and social costs of cancer. To learn more, visit survivornet.ca. This webinar is being recorded and will be available on YouTube, and a link will be provided by the email you registered with, along with a link to the slides provided with this presentation. This session is meant to be interactive, so please feel free to submit your questions in the questions tab on the right-hand side of the GoToWebinar application. This webinar is a joint venture between ourselves and Bayer, and we thank them for their support for this initiative and to help us continue our educational endeavors. The CCSN webinar series is also made possible by grants from AbbVie, Amgen, AstraZeneca, Eisai, Bristol Myers Squibb, Janssen, and Merck. Now, earlier this year, CCSN and Bayer executed a study on medical imaging. The goal was to uncover the patient experience and identify unmet needs and see how we can make the experience better for patients. We surveyed a group of 165 people, which predominantly skewed female and over 50 years of age. Due to the demographic of our audience, 95% of respondents have cancer, with 30% diagnosed with lung cancer, 13% with breast, and 11 with brain. We also had representation from pancreatic, melanoma, or ovarian cancer. Of the imaging scans received, 74% had an MRI, 58% received an ultrasound, 42% received a PET scan, and 20% listed another imaging scan, such as a bone scan or an X-ray. We asked what type of information patients wished they had before they got their imaging, and these were separated into 5 categories. The first piece of information that patients wish they were given beforehand were related to safety, so things like side effects, risk of radiation exposure, etc. Next was imaging modalities, for instance, the difference between scans and why those scans were chosen. Preparation was another category of information patients wished they had prior knowledge of. And so, for instance, information related to wait times, durations, parking, should I fast, what types of fluids do I need, should I be prepared physically or mentally, etc. Finally, patients wish to know beforehand what types of things scans were looking for and information around those results, specifically how long they needed to wait, how to access the results, and how to interpret those results. We asked respondents where they look for information about imaging or their condition, and we found 20% consulted healthcare providers, but 19% instead went to sources like Google. Trends showed that younger patients consulted Google more, while older patients trust HCPs more. 12% went to patient groups, and only 1% went to social media exclusively. Around 15% of respondents use a combination of all these sources. In terms of how familiar patients were with imaging modalities, 29% felt that they were well versed in the pros and cons about imaging and the differences between those imaging types. However, the majority, 56%, said they were only somewhat versed in their understanding of the pros and cons of imaging. For getting into the imaging itself, patients often faced barriers to accessing scanning. A full quarter of respondents listed anxiety as a major barrier. A large portion listed logistical barriers, like the scan site being too far at 16%, lack of convenient transportation at nearly 10%, and unable to take time off at 3.2%. Less than half of respondents listed other barriers like wait times or going to different areas to get scanned, or said they had no barriers to scanning whatsoever. The barriers that patients encountered didn't prevent them from accessing diagnostic imaging, but it did put a significant burden on them, whether in terms of financial cost, time, and mental health. However, they all pushed through despite these difficulties. Once the test was done, around half of respondents said they got a diagnosis within 3 months. However, around 18% were diagnosed 3 to 6 months after the initial visit, and 15% said they had to wait up to a year for their diagnosis. Around 12% of respondents to our survey had to wait over a year, with some of those patients 4% of the total, waiting over 5 years to get a diagnosis from their scan. 59% of patients got a record of their imaging reports, while 41% of the time, patients didn't receive a copy of their results at all. For those who explain the results, 55% of patients said an oncologist would explain the imaging results received. However, often someone else was on hand to explain the results, or many healthcare practitioners would be able to provide clarity around the results. Around 40% of the time, a surgeon would explain the results, followed by, in descending order, a general practitioner, a radiologist, or a radiographer. 16% of respondents also said that someone other than these people would explain the imaging tests for them. 18% of respondents said no one explained their results to them at all. Despite these issues, only 5% of people surveyed would characterize their overall experience with imaging as negative. Around 70% of patients, 70, and many left comments saying they appreciate the care of technologists provided during their scan and were overall positive. Around a quarter said their experience was neutral. Patients, however, note that the process was very long, reporting long wait times to get tested and to receive results. There was also a lack of clarity surrounding the results and a lot of concerns about the side effects and long-term radiation. Patients reported an increased peace of mind when they received routine scans for monitoring purposes. One final point to bring up revolves around the breast cancer patients we surveyed. Back in 2024, the Canadian Task Force for Preventative Healthcare released a recommendation to not systematically screen women between the ages of 40 to 49 and to not use additional screening for women that had a high breast density or a family history of breast cancer. Out of the 12 breast cancer patients we surveyed, 11 disagreed with those recommendations. Some of these patients said that they had received their mammogram invitations after they were diagnosed with breast cancer. Patients recognized the benefits of early routine breast cancer screening, the risk of dense breasts, and the family history component. The vast majority noted it was best to err on the side of caution with increased screening. Now, that is a lot to digest, so if you'd like to see these findings for yourself, we will include this infographic with the email we will send you with the results of the with video. We will also have a link to a feedback survey about this webinar so you can fill out at your convenience, which will help shape future activities and webinars. And so, with these findings in mind, I would like to introduce the first of our two presenters. Dr. Zahra Kassam is an associate professor of radiology in the Department of Medical Imaging at Western University in London, Ontario, and division head of body imaging at Western University. She completed her MD at University of Alberta, her diagnostic radiology residency at Western University, and a fellowship in body imaging at Stanford University. Dr. Kassam is very widely published with over 100 peer-reviewed articles and more than 1,600 citations reflecting her ongoing contributions to education, research, and clinical experience in radiology. And so with that, I would like to turn it over to Dr. Kassam for her part of the presentation, Reducing Scanxiety, a fireside chat of Q&A on diagnostic imaging.
Thank you, Trevor. Good morning or good afternoon, everybody, depending on where you are listening. It's my pleasure to be here today. That was a lot of very interesting information that we gleaned from the survey. So hopefully during the course of this presentation, we'll be able to answer some of your questions, and there will be time at the end to hopefully take some questions from the audience as well. So we'll just delve into the presentation at this point. So the presentation today does actually address the questions that came out of the survey. So we're hoping to target those areas that most people wanted answered during the course of this short talk. So we'll start with the different types of imaging modalities. What types of imaging modalities are available and what is the difference between them? So we'll address that now. So there's a multitude of different types of imaging modalities that you may have heard about or experienced yourself in the course of your diagnostic experience during your healthcare experiences at the hospital. Some of them have radiation associated with them, some don't, and we'll delve into that a little bit later. Many of you may have had an X-ray, as we see here on the screen, of the hand, and that type of study is actually best for sort of a quick diagnosis. It's very good for bones. You may have had a chest x-ray before, so it's great for assessing the lungs. And one of the best things about x-rays is they're portable. They can be portable. So sometimes we can bring the x-ray machine to the patient if they're too sick to come to the department. And they're very fast, and we can use them to follow up patients over time. And they have a lower radiation risk and a cumulative radiation dose than a CT scan would have, for example. And ultrasound is also used quite often. It can be a screening modality, like in the emergency department. If there's a patient with trauma, we can quickly look to see if there's any fluid in the abdomen, for example. It's used for screening purposes sometimes, for breast cancer. It can be used for looking at patients who are pregnant and assessing the health of their baby. And then one of the advantages of ultrasound, one of the biggest ones, is that it does not have any ionizing radiation associated with it, which is why we use it very liberally in Canada. It's widely accessible. And again, it has that advantage of being portable when needed. So for example, if a patient is in the ICU or in the emergency department, it's fairly easy to get access to ultrasound. The machines are small, and the availability and the expertise that's needed to perform an ultrasound is widely available across the country. Then we get into the more complex sort of imaging modalities that require the patient to go to the scanner. So we have a CT scanner, a PET scanner, and an MRI scanner. And usually, at least in Canada, most of the time to move yourself up to one of those scans, you would have had one of the more portable types of scans in a lot of circumstances, not always, but usually we try to start with a modality like X-ray or ultrasound first. That's not always the case for all body parts and all indications, but we try to do that where we can to save radiation risk. So PET scan, MRI, CT give us a little bit more detail about the anatomy of the body. MRI does not have any ionizing radiation associated with it, while CT and PET do. So again, we have to keep that in mind when figuring out what test is best for each patient. But we get a lot of detailed anatomic information because we're getting what's almost like a slice of the patient's body. So it's almost like, I try to explain to my students, it's like having a loaf of bread, looking at a loaf of bread versus slicing it up and looking at the detail inside. So that's what those types of scan give us. So we'll go to the next slide. Okay, so how do we choose these imaging modalities? I've told you about all different types, but how do we actually figure out which one is best for you at that particular time in your healthcare journey? Well, it depends really on the clinical question and the area of the body that we're examining. So whoever is referring a patient to the imaging department for a particular type of study has a question that they want answered. So as a radiologist, I'll look at that question, and it's very important that the question is phrased with as much detail as possible. So we always ask our physicians who refer to us to give us as much information as they can. And that helps me as a radiologist figure out, okay, I know this is what the patient is experiencing. I know these are the symptoms. I know what the family physician or the specialist is worried about. What test would answer that question best? So that's called triage. So we're getting the information. We're trying to figure out kind of what bucket it goes into to answer that question best. Based on the body part that needs to be examined and the question that needs to be answered, we have narrowed it down at that point to maybe one or two imaging modalities. So maybe an ultrasound might answer that question better. If we think that the organ or the abnormality might be close to the skin surface, for example, an ultrasound probe might answer that question very quick. Whereas if it's deeper, we might need a scan that has a little bit more detail, like a CT or an MRI. So that's just one example of the thought process that goes into choosing what modality is best. Then we think about the safety of the patient. So is the patient pregnant? Have they had a lot of CT scans before, and we don't want to really overburden the patient with more radiation risk? If that's the case, then we might choose an alternate modality like MRI or ultrasound that doesn't have ionizing radiation. And then we have to think about patient-specific things. Does the patient have any implants that are contraindicated with MRI? Do they have any allergies to contrast material? How urgent is the test? Is it emergent that we have to get this done yesterday, in which case an ultrasound might be really quick, or can it wait a few days or a couple of weeks? And those are all the questions that we go through to figure out what test is best at that time. Next slide. Okay, so as a patient, how do you ensure you're getting the right scan? It's always good to ask your healthcare provider lots of questions. And I think we heard from Trevor at the beginning that people feel anxiety when they're going through this whole process. And that's very understandable. And I think anxiety sometimes is rooted in lack of information. So the more information we have about anything that we're worried about, probably the better we'll feel, right? So getting more information is really helpful. So whether you get that from Google or ChatGPT, or you ask your physician about it, having more information is power. So that's really important for you to understand your disease and to figure out why we might be asking for certain tests. So that's kind of the patient role. Radiologists like me, we have a lot of information and knowledge about the strengths of each modality and about the diseases that people may experience over time. So putting those two pieces of knowledge together about the disease and the test helps us figure out what test is best. So sometimes a doctor may say, can I have a CT scan for this? We may send it back, send the paperwork back and say, actually, this test will be better for that. So there may be kind of a back and forth dialogue between your doctor and the radiologist based on different levels of expertise. And then in Canada, as I talked about, we triage all of our requests that come in. So we sort of order them by urgency and by the type of modality and the type of disease. So every day when I go into work, I have a stack, a paper stack and an online stack of requests for imaging tests. And I go through them all and I prioritize them by how urgent they are, what they're for, and what modality they are best suited for. Next slide. Okay, so we'll change gears a little bit, and now we'll talk about immediate and long-term risks of imaging tests. So one of the helpers or tools that we use for our imaging modalities are contrast media. So you might have experienced that yourself, where you're given something to drink by mouth, a contrast agent, or you may have had contrast material administered to you via an IV, which is very common. So we'll go to the next slide. And there's other types of contrast material as well, but I won't get into all of them. But the reason that we actually give contrast is because it actually helps us see the anatomy and sometimes abnormalities a little bit better. So when you drink a certain agent for a CT scan, for example, it highlights a particular part of the body that we're interested in. And then when we inject IV contrast for certain scans, CT or MRI, that contrast material makes the organs of interest show up a little bit better. And then there might be certain diseases that we're worried about that we are looking for, and those diseases will show up better with that contrast material. So that's why we actually administer contrast. Sometimes we do a test without contrast because a patient might have an allergy or because they don't want the contrast. And that is the choice of the patient. You can decline the contrast. You will be asked for your consent. However, it is important to be aware that without contrast, when it's recommended, our diagnostic accuracy level actually goes down. So if you are recommended to have a study with contrast, it's probably best to proceed that way because there is a reason for requesting it. Next slide. Now, with any item or pharmaceutical that's administered outside the body, it is kind of considered a drug. So contrast material can be considered a drug or a pharmaceutical. There obviously is a risk anytime we do that. So we do share those risks with patients before we administer contrast. The risks are very small, but it is important to be aware of them. So the first one is the risk of an allergic reaction or an anaphylactic reaction. Those are very rare. And they used to be more common when we used older types of contrast agents about 20 or 30 years ago. Over time, the risk profile of these contrast agents has improved significantly so that the risk of an allergic reaction is now extremely rare. But we will ask you about whether you've had a reaction before. And if you had, we will give you an alternate agent so that the risk of reaction, again, is very low. There's a very small risk of kidney damage in patients with known kidney disease or who have renal transplants. And in that case, we will check your kidney function before we administer a contrast agent. And we may decide either to not give you contrast or to use a different modality, for example, an MRI, depending on how your kidneys are working. There's a risk of extravasation. So what that means is when we put in the IV to give you the contrast agent, in a small number of patients, the contrast agent might leak out of the IV site and go just below the skin surface, and it can actually cause some local irritation of the skin. So that's also a risk, but again, that's very low nowadays because the technology that we use for the IVs and the power injectors we use is very good, so just a small risk. I just put a note in there also that with breastfeeding, contrast agents are still safe. Some people prefer to pump and dump after the study is done for 24 hours, and that's totally fine. It's also fine to keep breastfeeding after a contrast study. Next. How do we reduce risk when we're administering contrast agents? Well, I talked a bit about screening already. So before you come to our department for any kind of imaging study, there's usually a screening procedure that is sent out, or a questionnaire to your physician. So we'll ask about allergies, we'll ask what medications you're on, we'll ask if you're pregnant or if you have reduced kidney function. And after we get that information, then we'll make decisions as needed. We always use the safest type of contrast agent and the lowest dose that will help us to answer the question. So we don't have any of those older agents that used to cause a lot of allergic reactions anymore. Nobody really uses those. And we're always kind of looking for the newest and the safest agents. Like I said, if you had a previous allergic reaction, we will switch agents so that you're not given that same offending agent. We always have on-site monitoring and trained technical staff and radiologists so that if a reaction happens, we can treat it right away. And then we have those alternate modalities sometimes that don't always need contrast. Sometimes they do, but usually we can function without it if necessary. Next. Now today, as I said, we use safer and lower dose contrast agents. So we have fewer reactions, we have less local irritation, less kidney effects that are negative. And what's really interesting is with the advent of AI growing in the healthcare industry, our scanners can now use a lower dose of contrast agent and kind of make up the difference in the contrast that we would get with a bigger dose using AI. So the AI can kind of extrapolate and figure out, okay, with this small dose, if I was to magnify that by 80 or 90%, what would it look like? So we're getting to a point where we're needing less and less contrast over time, which is fantastic. We do use personalized dosing. So we will ask for patients' weight before they come to the hospital or to a clinic for a study. And because we have that information, we can tailor the dose of contrast for each patient. We talked a little bit about the kidney safe pathway. So we'll screen for your kidney function. We might give you extra fluid if your kidney function is a little bit kind of on the fritz, then we'll help to make sure you're hydrated. And then we have safer injection technology now. So things are always improving, and we're using all of the technology that's at our disposal to help make these studies as safe as possible while still providing the information that's needed to make a diagnosis. All right, and I will just pass the baton to Stuart at this point.
Yes, thank you very much, Zahra, for that presentation. So to continue the presentation, I would like to introduce Stuart Brice. He is originally from Perth in Western Australia. He has been working in pediatric radiology for almost 25 years, including a few years in Australia, England, and Ireland. He started at BC Children's in 2014 and a MRI technologist, later becoming the supervisor of CT and X-ray. And so, Stuart, I would like you to take it away.
Thank you so much, Trevor, for that introduction. And it's truly a privilege to be joined with Dr. Kassam and you good folks today to go through some of these questions and to go through the findings of the study done to try and alleviate, some of this scan anxiety or scan anxiety to try and make your journey much easier. The first question that I'm going to talk about here is this idea of radiation and risk And it's really understandable that people feel pretty scared when they hear about this word radiation, the idea of nuclear warfare or nuclear power plants or Fukushima and Hiroshima. All these kind of things come to mind, and it can be really daunting and really scary. And let me try and help you alleviate those risks. So let's get into the next slide. The good thing about the use of radiation in most parts around the world, but especially in Canada here, is that we are regulated. So the amount of radiation that patients can be exposed to is regulated by Health Canada. And so we're out there trying to make sure that you're going to get the lowest amount of radiation and that we're not exceeding these dose amounts that are regulated by Health Canada. For the different types of imaging modalities, Dr. Kassam spoke about at the beginning between CT and X-ray and nuclear medicine. The more modern machines can record how much dose you get per study, and we can work out how much radiation you've had over a period of time. And the reality is that there's an incredibly small chance that throughout your studies and through all the different tests you have, that you'll ever get close to a dangerous amount of radiation. And the reason behind that is that we use this principle ALARA. So this acronym stands for as low as reasonably achievable. And what it means is that regarding each of the different tests that use radiation, we use the smallest amount possible in order to achieve the images required. We don't want to use too little so that we can't diagnose what's going on or to see clearly what's going on in your images. We don't want to use too much because there's no reason to overly expose patients to radiation. So we like to err on the lower amount. And another thing to keep in mind here is that the manufacturers of the different machines, the different scanners that we use, they work really hard to develop technologies to try and have scanners that use the lowest amount of radiation to produce the images that we like to see. For them, it's part of a marketing ploy, and again, it just tries to increase the likelihood of people maybe buying their machines over one of another vendor because they say that they use less radiation. Dr. Kassam touched on this as well, that we've had a huge increase in technology over the last bunch of years. Even with yourselves, if you go back to using cameras. Not that long ago, we were using cameras with film. Now we all have digital cameras or just use our phones. Similarly, we've had the same kind of technological increases in imaging. So no, we don't have film that we put up on light boxes anymore. Everything is on computers, and the images that we acquire now require less amounts of radiation to get them, which is great for patients all around. Let's go to the next one. So Dr. Kassam has also touched on this at the beginning of the presentation, that we have all these different types of modalities, these different types of machines, these different types of ways to achieve imaging. Some of them use radiation. They include the X-rays, the CT scans, PET scans, and nuclear medicine studies. And other types of imaging doesn't use radiation. MRI and ultrasound are two modalities that don't require radiation. For me, in my pediatric world of medicine, we really like to use MRI and ultrasound as much as possible so that children aren't receiving radiation dose. And as Dr. Kassam said, the same theory is applied to adult patients as well. If we can get an answer with a study that requires no radiation, then for sure we're going to go for it. Sometimes we do need to use radiation. The example of having a CT scan, we get a lot of information, we get it really quickly, and that's going to help both the radiologist to answer the clinical question that your doctor's asking to answer. And it also helps you to get you in and out of imaging facilities faster with really efficient imaging, and we get lots of information from those scans. But we've thrown a lot of different numbers at you, a lot of different ideas, but how do you compare one type of radiation source of imaging, X-ray or CT, to another one? How do you compare those? So one really good way to do that is to compare it to the amount of background radiation you're exposed to on a daily basis. We can go to the next slide. So we are exposed to radiation being on Earth day in, day out. That's part of living on this planet. Here are a few examples of how much radiation that really is. So if you go to the dentist and have a dental X-ray, that amount of radiation is about equivalent to flying from Toronto to Vancouver. You might ask, how is there radiation when you fly? Well, you're up higher in the atmosphere, you're closer to the sun, you're receiving more cosmic radiation from space. So this is how these sources of radiation. Other common studies, as we've spoken about, there's chest X-ray, CTs, and PET CTs. Chest X-rays are pretty low amounts of radiation, about equivalent to around 10 days of background radiation. CT scans here, 4 to 5 years, and a PET scan a little bit more, of 12 years. What are these sources of background radiation? Like, where is this stuff coming from? I mentioned cosmic radiation from space and from the sun. There's fallout in our atmosphere from the use of nuclear weapons and the testing of those weapons. But a major source of radiation around the world is from radon gas, which is when uranium breaks down in soil and rock and water, it leaks out into the atmosphere, and that accounts for a huge amount of radiation, background radiation for us as people on Earth. Next slide. So here we have a little graph side by side comparing different types of scanning modalities: X-rays, dental X-rays, chest X-rays, mammograms, CT scan, a CT of abdomen, and then a PET CT. And you can see that as we get lower in the graph here, the amounts of radiation required for those different types of tests is ever increasing. Down the bottom, we have this thing called effective dose, and we measure this stuff. We measure effective dose in a scale of millisievert. And we can compare background radiation, for instance, to the amount of radiation that these machines require to produce their pictures by looking at this millisievert values. We can take a look at the next slide, please. And so here we have in the red box in the top left there that the background radiation in Canada is around 1.8 millisieverts per year. That amount of background radiation will change depending on where you live in Canada. And next to that in the green box, you'll see that an X-ray of a chest is equivalent to 0.1 millisieverts. So equivalent to around about 10 days of radiation dose of being on Earth. As we go through the next one, to the purple box, a CT scan of the chest, around 4 years of background radiation. We have an idea of what can happen if we apply a certain amount of radiation to a patient. These are called deterministic effects. So we know if we give this dose of radiation that we'll have this impact on a patient. Sometimes those impacts can look like radiation burns, so like a sunburn. And to achieve that amount of damage to a patient, we need to have pretty high amounts of radiation, and certainly nowhere near the levels that you're going to get by having regular X-rays and CTs and PET scans and nuclear medicine scans. We don't know a lot about radiation and its impact on cancer to a really great degree, because the data that we go on to extrapolate information of what happens if you get exposed to radiation is really based on the survivors of the Hiroshima bombings many, many years ago. So being exposed to huge amounts of radiation, does that then lead into developing cancer? That's the stuff we don't really know about. We know if we apply this amount of radiation, we might get a burn to a skin, for instance, but we don't know if we have all these amounts of radiation along the way, what really happens with that. The science that we have behind it so far is that having multiple imaging tests along the way in your life doesn't significantly increase your chance of developing cancer. In order to have this in the orange box here, we talk about this radiation sickness, we need to have 1,000 millisieverts here. So if we go back to the chest X-ray, which is equivalent to 0.1 millisieverts, you'd have to have a lot of chest X-rays to have the amount of dose required to have acute radiation sickness. You can go to the next slide, please. Again, another side-by-side graph here demonstrating that in the middle bar, we have the amount of dose required for a chest X-ray. To the left, how much radiation you receive in a year, just in background radiation, and on the right-hand side, a chest CT. So again, a chest X-ray is a very small amount of radiation compared to the amount that you get from background, and it is only about 4 years or so of background radiation. When you compare it, the CT scan is equivalent to about 4 or 5 years of background radiation. So these aren't huge amounts of radiation when we go into the whole scheme of things. Go to the next slide, please. So why would we choose to have scans? What's the risks associated with, like, why would you choose to have one or not to have one? The reality is that if your physician is asking you to have a scan, whatever the type it is, then it seems to be medically indicated. And what I mean by that is that if you don't have the scan and you don't have that CT scan, you don't have that PET scan or X-ray, there could be a chance that we're going to miss something. And if we miss something, that's going to really impact your diagnosis and your treatment pathway. So if your physician is asking you to have a scan, of course, question, why am I having the scan? What's it going to show? But the reality is that the information we get from that scan is going to be helpful for you in your treatment, and it's going to be helpful for you in making sure that you're going to get the best care. Again, this amount of radiation that we use is always as low as reasonably achievable. We use very small amounts with again, this X-rays being chest X-ray being a very small amount of background radiation per year. And then in order to have some sort of damage to DNA or to strongly increase the likelihood of cancer, you have to have significant doses of radiation, and we just don't get those in day-to-day medical imaging that we use. We can see now that about 40% of the population develop cancer, not because of medical imaging tests. And the science behind it again is that even if patients have developed cancer, that the likelihood of developing different types of cancer after that, of being exposed to radiation, is very, 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 very small. And again, it's this weighing up of, do I want to have the best chance of getting through this, the best chance of getting a diagnosis and treatment, and making sure I'm getting the appropriate treatment? And if the answer to that is yes, then yeah, continue to have the tests that your doctors sign you up for. Go to the next slide, please. So we have all these different types of imaging: MRI, CT, X-ray, ultrasound. So how do you prepare for these different types of scans? They all have different preparations for them. And just before I get into the next slide, I think the important take-home message here is that each of these different types of scans have different types of preparation. And if you're having the same test at two different facilities, they might have different types of preparation. So the important thing is to follow the instructions that are provided for the test that you're going to. So let's get to the next slide, please. So when you receive an email, a letter in the mail, or a call saying that you're coming to have a scan, follow the instructions that are for that site specifically. So in some of the tests, we may ask you to hold your breath. And for other tests, we might ask you to make sure you drink plenty of water before you come into the scan. Sometimes we'll ask you to not have any food for a bunch of hours before the scan. So whatever the instructions are given to you, please follow those, because that makes sure that you're going to get the best test quality that you can get. If you don't hold your breath in some of the studies, then we're going to get suboptimal imaging. If you have a bunch of food and we're looking at your abdomen, and it could really impact us seeing clearly what's going on in your abdomen, and maybe hide pathologies or hide something we really want to see that's going to help you with a diagnosis. Through all of this, you can talk to your technologists. So people like me, we love our scans to go smoothly. We love to make sure that our patient experience is the best. So if you're asked to hold your breath and it's too long, then tell us, and we can try and tweak things and alter things to try and help it so it's achievable for you. If you get on the scanner table or the bed and it's really uncomfortable and you just need a pillow underneath your legs, then please ask for it. I really hope that my colleagues ask that question before going to start the examination of, like, are you comfortable? Are you all right? But if they don't, and there's something that you require, then please just ask them. There's certain things that we don't like to have for some of the scans. One big thing is metal. So metal can really, really impact the quality of CT scans. So if you've got a hip replacement, a shoulder replacement, or something like this, it kind of skews our images a little bit. We get these sort of white streaks going across the scans. And if we know that you have metal in your body, then we can, again, choose different techniques to try and make it so we get the clearest pictures we can. Metal in MRI is one of the most significant things for us to watch out for. So if you have had a previous surgery, again, shoulder replacement, hip replacement, knee replacement, something with an aneurysm clip put into one of your arteries, a pacemaker inserted into your body. We really want to know about these sort of things. There are some sites that won't scan patients who have pacemakers. And so you could travel the distance to get to a site to have your MRI scanned, have a pacemaker in, and that site may say to you, oh, sorry, we can't scan you here. Some sites do scan pacemakers, for instance, so it's really important for you to tell us what's inside of you, and to ensure that we're making sure that your safety is our priority. I get a lot of patients who, when they're going through the different paperwork of answering all these medical questions, sometimes they'll say no to a question because they don't quite understand it. Please just ask your technologist, what does it mean by this question? What does this surgery mean? What's this word or this abbreviation mean? Because I've had lots of patients who have answered no to a whole bunch of questions on their screening forms, and then you ask a little further into these questions, a little more information to the background, and they'll say, "Oh yeah, I did have metal go into my eyes from my job because I work as a mechanic, or I did have a pacemaker put into my heart, but it was like 15 years ago." We really want to know about all these things because it's incredibly important. Other preparations for some of your studies might be for ultrasound is to drink beforehand. This can help increase the urine volume in your bladder, and again, it just makes it easier for us to acquire images, particularly of the pelvis when you've had water, for instance. Pregnancy is another huge one we want to know about. Please tell your technologist if you are pregnant or if there's a chance of being pregnant. We want to avoid the use of radiation when patients are pregnant unless it's completely necessary. And if we know a patient's pregnant or is likely pregnant, then we might change our course and go use a different type of imaging to try and figure out what's going on with the patient. Some sites offer the ability for patients to bring their own music and listen to music when they're having their different scans done. Again, this is different from site to site. And so if you have a particular type of music you like, bring it along, and you might be able to listen to that while you have your scan done, because these different tests go for different amounts of time. A chest x-ray, pretty quick. You go in, you get changed into a gown, you go up against the little x-ray board thing, have an x-ray, and you're done. A CT, a little bit longer, sometimes it's about a 5 or 10 minute examination. Ultrasounds, maybe 20-ish minutes. And MRIs can be pretty lengthy. They can be anywhere from half an hour to an hour, even up to 2 hours. So it's really important for you to be comfortable throughout these exams. And again, I think, as Dr. Kassam said initially, anxiety can strongly be reduced when you have information. And when you're educated about what's going to happen and what to expect, then there's a great likelihood that the exam is going to go smoothly for everyone. Thank you.
Thanks, Stuart. So I'll just hop back on here for the last couple of slides. So now you're probably wondering, well, what happens after I've followed all your instructions, I've filled out the screening form, I've had my scan, now what do I do? You're waiting for the results, and how do I access them? So we'll go to the next slide. So imaging reports can actually, the timing can vary widely from institution to institution, and can also vary based on the type of study that's done. So usually x-rays, because they're quite quick, and they don't have a lot of images associated with them. It's usually only 1 or 2 images. The reports are usually done the same day or the next day. The more complex a test is, the more images there are, the longer it takes to interpret. So a CT scan or an MRI scan might have hundreds of images or thousands of images. So as you can imagine, it would take a radiologist a lot longer to interpret a study with more images than it would a test with 1 or 2 images. So that's one of the variables to consider. Another variable is the fact that we try to compare the results of the most recent study to older studies that you might have had in the past. And sometimes those are available to us right away. Other times we might have to request them from another hospital, and it takes days or weeks sometimes to get those prior images sent to us so that we can do a comparison. If we don't do that comparison, then we're kind of wandering around in the dark with a blindfold on and not really being able to provide the level of diagnostic accuracy that we would want for you so that you can get the best treatment. It's really important to see what happens over time, especially in patients with cancer, where we're monitoring what's happening to their diseases. If I don't have the prior study, I can't really make a conclusion as to what's happening with the disease. So that can sometimes be a bit of a roadblock. It's gotten a lot better with digital imaging, but not all hospitals are connected on the same network. So that's why there may be some delays in getting prior imaging, but that is really essential for interpretation in a lot of cases, especially patients who are undergoing routine surveillance for cancer. Some centers might have other kind of steps that we go through before a study is finalized. So at teaching hospitals, we often have residents and trainees and fellows that are looking at the studies because they need to get the experience in looking at these cases so that we have future radiologists to look after our population. And sometimes that can actually cause some length. It can increase the length of time that's required to issue a final report. And sometimes it depends on how the patient has access to the reports. So I think a lot of institutions now have their own digital or online access for reports. The hospital I work at uses Pocket Health, and that might be the case for the hospital that you are most closely associated with. So I would encourage you to reach out when you have your next visit to the imaging department to actually inquire about what's available to you to be able to access your own reports. And it's usually very quick to do that. Usually you just scan a QR code and then you get access to your imaging reports. But usually it takes a little bit of time to get the final report in. One other issue that I forgot to mention is sometimes I might need to call a clinician to ask about some information that's really important to me before I make a decision on issuing a report. So sometimes the clinical information is what I'm waiting for as well. But on average, shorter imaging studies usually take 1 or 2 days. Longer imaging studies might take a week or 2 weeks sometimes at the longest, but we try and get the reports out as quickly as we can. In terms of how you can figure out what's going on with you or get explanations to your report, usually a healthcare provider who requested the study will explain the results to you. In some cases, if you are coming to an imaging department to get a study done, in particular in breast imaging, radiologists may be able to tell you a little bit about what's going on at the time, but most of the time, we can't tell you in real time what the results are because we need to review the images in further detail, or we might need your prior studies and we need to take the time to do that comparison. So it's not very often that the results are given to you on the same day or while you're having the test. And that's not because we don't want to share them, it's just because we need the full information to actually make a conclusion. So that's why it takes a little bit longer to get that information. Okay, next slide. And just to finish up, we just put here some resources that might be useful to you to learn more about what we've talked about today. So we have the Canadian Cancer Survivor Network website. Bayer has a lot of information on their My Radiology Scan website. Choosing Wisely Canada actually has a lot of very useful information about safety in medical imaging. If you're wanting to know more about radiation risk or contrast risk over time, Choosing Wisely is a good resource to go to. Radiology Info is administered by the Radiology Society of North America, and they actually have a lot of information there about guidelines for medical imaging, preparation for different studies. If this kind of went over your head and you need more information on that, or you want to go back and refresh your memory, that's a very good resource. And then just another plug for your own hospital's patient portal. So it might be MyChart or Pocket Health. And just to suggestion to find out more about that and plug into that at your local hospital so that you have access to your own results. All right.
Excellent. Thank you so much for this presentation, both of you. It was very eye-opening. We already have a lot of questions, so but you know, the more the merrier with this one. If you could put your questions onto the GoToWebinar tab, we already have several waiting right now, so we'll get right into those. First off, I'd like to talk about Gary's question. Are the radioactive units calibrated to base level on regularly scheduled time format, and are they inspected by government agencies?
I can take that. There is pretty strict quality assurance and preventative maintenance schedules that we have to follow on a daily basis in most cases to ensure that the machine is operating safely and the machine is operating at levels and producing information that is reliable and reproducible. So between preventative maintenance from the vendors and our daily quality assurance, yeah, I'd say that it could be quite trusted, the information that you're receiving.
Mm-hmm. Now, another question. Thank you for the amazing talk from Leslie. Here in Nova Scotia, we are working with community members to produce a short education video on reducing scan anxiety for LSCT chest. This talk was very timely and helpful. The comparison of radiation exposures from medical tests versus ambient exposure from simply living in the world was helpful. So thank you very much for that. She meant LDCT instead. Now for the other questions, one from Sheila. She is a colon cancer patient in observation with contrast CTs with iodine and barium every 3 months, and she's concerned about her kidneys. What risks are associated with iodine and barium when it comes to those scans?
Okay, so maybe I can tackle that one. So barium is actually inert, so it really has no effect on your body other than it just gets excreted. So there's really no worries there. In terms of iodinated contrast, the only risk is for patients who have pre-existing kidney disease. So if you've had a kidney transplant or your kidneys are already non-functioning or poorly functioning, or you're seeing a urologist for kidney disease, then we would be a little bit more concerned about giving you iodinated contrast because the way that the kidneys clear it, it depends on having good kidney function. But if you don't have any of those issues and your kidneys are already healthy, there's no added risk to having iodinated contrast, and it doesn't increase your radiation risk either. So it's perfectly safe as long as your kidneys are functioning well.
Mm-hmm. More questions are more than welcome in the GoToWebinar app. I apologize for the phone going. We are busy here as a work day. But for those who are still on the chat, if you'd like to talk about your experiences, what made imaging more comfortable for you, please put that in the questions tab. Sue asked, my husband was given IV fluorescein dye to image his eyes when diagnosing his posterior uveitis. An otherwise healthy person, he had an immediate fixed anaphylactic reaction as well as severe vomiting that lasted 12 hours and ended up in the ER. He never received contrast dye before and no prior history of allergies, but now wears a medical alert as he has developed other medication allergies. I was wondering in that case, how you mentioned that these kind of reactions are very rare. Is there any ability to kind of catch something like this ahead of time?
So fluorescein and our iodinated contrast agents are not related at all. So that study would have been done by an ophthalmologist. It would not have been done in medical imaging. So yeah, there's really no overlap in terms of the fluorescein and what's administered in the medical imaging department. In terms of can we catch this ahead of time, that's a good question. We used to ask certain questions of patients that we thought might give us an idea of the risk, but it turns out over time and over science and studies that even those questions that we asked are not related to the risk of allergic reaction. So I guess what we do is we treat allergic reactions right away as soon as they happen. But again, it's very rare for that to happen. If it does, then we just don't administer that agent again. So it's like asking, can we predict that my kid is going to have peanut allergies? It's really hard to know until you give the peanut, unfortunately. So, so there's really no good way of predicting an allergic reaction. All we can do is treat it right away if it happens and prevent it from happening in the future.
Mm-hmm. And one more time, if there's anything about radiology or safety anyone would like more clarification on, please go right ahead. Gary asked a very interesting one. Could you explain the physical chemical reasons why the image is better with contrast agents in a scan?
Oh, that's a very good question. I'll try and address that, and maybe Stuart, you might want to pop in as well with the physics side of things. So with iodinated contrast, what happens is when iodine is injected into the body, it actually increases the density of the organs in the body. And when that density is increased, we can actually see them better on a scan. So if you think about an X-ray, and I showed you that X-ray of the hand, you could see the bones really, really well because bones are dense. So what we're doing is we're increasing the density of the organs so that we can see them better. And if there is pathology there, any disease, the density of that disease also increases. So that allows us to actually see the disease a lot better than we would without contrast. So it can be very challenging. If I don't have contrast on a scan, I have to rely on the density differences that already exist in your body. So for example, there's a different density in your bones compared to your lungs, compared to your abdomen, compared to fat versus muscle. I have to rely on that. But sometimes I can't really distinguish between what's normal and what's abnormal until we give that iodine. And if there's an abnormality, it will kind of soak up that iodine and it will be visible to me. So that's the best way that I can describe it for CT. And it's a similar concept with MRI.
I think that's pretty good, because I get asked this a lot of like, why am I getting contrast? And the stupid answer I give is, well, it makes the pictures prettier. And what I mean by that is that Dr. Kassam and I, we live in a world of black and white and shades of grey. And determining if we're looking at a piece of anatomy and is it this thing or is it another thing? Is this different shade of grey swelling or is this different shade of grey infection? You put in contrast, the infection soaks up the contrast we just gave. And so instead of being a shade of grey, it turns to become something much brighter. So it just makes our lives a lot easier in terms of diagnosing, and just really helps us to figure out what is going on and what is what when it comes to these different pictures.
Mm-hmm. We have time for one more question. Alex asks, when preparing newcomers or immigrants for an imaging procedure, have you encountered any cultural differences or challenges? If so, what were those challenges and what strategies did you use to address them to make them feel as comfortable as possible?
I can start.
Sure, and we can probably both answer that one. Go ahead, Stuart.
No, absolutely. Cultural preferences for anybody are taken really seriously at any professional medical imaging facility. Sometimes patients may have a preference for a female over a male technologist or physician, and we try and accommodate that as best we can, whenever we can. We often find that there is sometimes a language gap, and that we're asking these kind of very medical questions that have this strange language to people whose English isn't their first language. And years ago, I'd have to have an interpreter on the phone or present with me, and to like ask the interpreter the question. They then ask the patient, and we go backwards and forwards. Things have come quite a way now in that we have this iPad we roll around from patient to patient who requires interpretation, and we can just have a real-time conversation with somebody on this iPad who can do the interpretation for us. It streamlined the whole process a lot more, and I think what it does in particular is give the patient the ability to ask questions in their first language and be responded to in that same language. So again, reducing their anxiety and trying to make them more comfortable in the situation as best we can.
Yeah, I think Stuart really addressed the crux of the matter. It's trying to make the patient comfortable. I think if the patient is comfortable and they feel like their questions have been answered, then the test usually gives us very clean results in that it's easier to make a diagnosis. I find that if the patients don't really understand what's happening with the test and they don't understand the directions, that's when we run into situations where we might not get a good quality test. And our goal is to get the best quality test we can so that we can get the result that we're looking for. So I try and just explain as much as I can to newcomers, whether it's a language barrier or a cultural barrier, or they just feel like they don't have the information they need. I think it's important to take the time then to answer any questions. We do sometimes use technological novels like Google Translate. Sometimes on my iPhone, I'll just type in there, and then it'll read out in the language of preference of the patient. We'll just take a little bit more time, and I think that that time is very well spent. Sometimes there may be parts of a test that a patient is not comfortable with for cultural reasons, and then obviously we don't proceed with that. We might try and find an alternate way of getting the answer that we need. So the patient is really the person in charge, and our job is to make sure they feel comfortable and they're aware of why we do certain things. I think what we need to do is just explain why we're doing that. So that's what we're doing today. We're trying to explain, why do we do all these things? Why do we give contrast? Why do we do this kind of study? And the goal is just so that you have all the information you need to feel comfortable.
Mm-hmm. Sorry, go ahead.
So from my side of things, the technologist side of things, the machines are pretty clever these days. If there's a breathing instruction that a patient has to follow, like breathe in and hold your breath, you can get the machine to use the language. You can program it to speak in whatever language that the patient speaks, and so they can hear the instruction of breathe in and hold your breath, not in English, but in the language that is more familiar for them. So that's another little tweak, a little trick that I use from time to time as well.
Excellent. I would like to just point out that in the chat, we have a survey that people can fill out. So if you would like to fill that out whenever you have a second, that'd be fantastic as well. But it will be in the email that you will get after this presentation. We have a couple more questions real quick. Ali also asked, is there a concern doing MRI and chest CT on the same day since two different contrasts are injected on the same day?
I actually just had this question a couple of weeks ago at our hospital. So there's no problem having them done on the same day, but we might just change the order. So it might be better to do the MRI first rather than the CT, because if you're getting contrast on your CT, it may just change the way the images look on the MRI. So that's really the only caveat of having two on the same day, but otherwise there's no problem with that.
Mm-hmm. Jill asks, why is there not a standard format for scan reports? I have metastatic cancer and have routine scans, but sometimes they are very detailed, which I appreciate, but many times there's only a few sentences in the report. That's what causes me a lot of anxiety.
It's a complex question. There's a complex answer to it too. So we try and keep our reports standardized as much as we can, but sometimes it's actually easier and better to directly give a report without that standardized format. And really it's because the person reading the report, it's easier. What we're trying to do is cater to the physician who's asked us the question. So yes, patients read the report as well, but the physician who's asked the question really needs to extract that information and act on it. So what I try to do when I report is I try to make it as easy as possible for the referring doctor to get the information they need. So sometimes it's with a standardized format. Other times it may be a very complex case and I don't use the standardized format because they'd have to wade through a lot of irrelevant information to get to the point of the story. So I sometimes will start with what's most important so that their information is right there. So I kind of think about it when I teach my residents and fellows. I tell them, people's attention wanes as they get through the middle of a long dissertation. So what you want to do is make sure that they get the information they need right at the beginning. So sometimes in a complex case, that might be why there's no standardized report. Short reports, it just depends on why the study was done. So the length of the report has really not much to do with the importance of finding. Sometimes there might be a short report because nothing has changed, or it's like a modality that doesn't have a lot of images. And sometimes it may just be the way the radiologist tends to, their habit is shorter. Usually a shorter report is a good thing because there's not much to say. So there's a lot of different variables at play in terms of why that might be the case, but hopefully that explanation gives you a little bit of an answer.
Mm-hmm. And the final question, Lexi says, my husband was recently diagnosed with stage 1 clear cell renal cell carcinoma. This was diagnosed following a radical nephrectomy. He is 5 weeks post-surgery. His kidney function for his one remaining kidney is normalizing. Are there any concerns with different contrast for someone with one kidney with kidney function values within normal limits?
So if the kidney function is within normal limits, we usually, and there's been a nephrectomy, like in this case, we usually have a discussion with the urologist and we'll decide together, do we need to give some extra hydration to the patient afterwards to make sure we flush out that contrast, or are they feeling comfortable enough with the kidney function that we can proceed with a normal CT scan? Sometimes we might just be able to make do with MRI or ultrasound, and we can avoid giving iodinated contrast at all. But it really depends. It's a kind of a case-by-case decision because it depends what we're looking for in each patient. Sometimes the urologist might be looking for something specifically that can be answered with contrast only. Other times it's just a general screen. So depending on the reason for the study, we can make those decisions with some dialogue.
Mm-hmm. Well, Dr. Kassam, Stuart, thank you very much for the presentation. A lot of good questions and a lot of fantastic information here. Really good grounded information for those who are going through scans. So thank you very much for your time.
Pleasure.
Thank you very much.
If you have any additional questions, you will be able to reach out to myself in the email that we send you. It will have a copy of the survey that we have a link in the presentation. It will have the images of for the survey itself, and of course the video and the slides as well. This webinar was a joint venture between ourselves and Bayer, and we thank them for their support for this initiative and to help us continue our educational endeavors. The CCSN webinar series was also made possible by grants from AbbVie, Amgen, AstraZeneca, Eisai, Bristol Myers Squibb, Janssen, and Merck. Now, this is one in a series of webinars that we are presenting this fall. Our next one is happening later this month. So to stay in the loop about webinars, visit our website or check your email for our e-blast. If you're not seeing our email in your inbox, please check your spam folder because we do use a third-party email service. And make sure that you are subscribed to our newsletter on our website to not miss what we are doing here at CCSN. All webinars can be found at survivornet.ca/webinar or on CCSN's YouTube channel. And so with that, I wish everyone have a good afternoon, and we will see you on the next one. Bye for now.